persons, ladies and gentlemen, at the outset, I would like to thank my batchmate, my friend Dr. Vitul Gupta for inviting me to Bathinda. I belong to this part of the country and it's a pleasure to interact with my class fellows, my colleagues and people who I grew up with. I bring you greetings from the Indian College of Physicians. My brief this morning is to talk about seronegative arthritis. We need to get this going. Now, seronegative arthritis by definition is an arthropathy which is characterized by the absence of rheumatoid factor. Now, this is a definition which was set up in the times when rheumatoid factor was the only serologic abnormality known to typify inflammatory arthritis. And by definition, an arthropathy where rheumatoid factor was absent was called seronegative arthritis, and this is something which over the years is now changing, as we shall see in the course of my talk. Before we embark upon seronegative arthritis, I think it's worthwhile spending a few minutes on rheumatoid factor, the bedrock of the serologic diagnosis of inflammatory arthritis for many years. Now, this is something that all of us know, that these are IgM antibodies against IgG. This is the time-honored latex test, and we now also have ELISA's nephelometry for detection of rheumatoid factor. Rheumatoid factor was first described way back in 1939-40 as the Rosewaller test when the sheep RBCs were used, and this was the abnormality found in patients with rheumatoid arthritis, which happens to be the commonest inflammatory polyarthritis that you and I encounter in clinical practice. I must mention here that rheumatoid arthritis is by no means the commonest joint disease that you see in clinical practice. That distinction belongs to osteoarthritis, but when we talk about inflammatory joint diseases, particularly polyarthritis, it's rheumatoid arthritis which is the one that we encounter on the bedside in our clinics, affects about 1% of the adult population. The first and foremost thing that I would like to do here is dehyphenate rheumatoid factor from rheumatoid arthritis, and this is critically important. Both can coexist independent of each other. Rheumatoid factor is present only in 80 to 85% of the patients with rheumatoid arthritis. So, you are going to have a substantial number of patients who do not have rheumatoid factor, and conversely, rheumatoid factor is not the exclusive preserve of rheumatoid arthritis. You can have rheumatoid factor being present in conditions other than rheumatoid arthritis. So, you need to delink the two. If you look at rheumatoid arthritis, this is a diagnosis that you make on the bedside on clinical grounds. You actually don't need any investigations to diagnose rheumatoid arthritis. It is much like chronic bronchitis, which is diagnosed on history. Rheumatoid arthritis is diagnosed on the bedside when you have a patient presenting with bilateral symmetrical inflammatory polyarthritis involving the hand joints with a duration in excess of 6 weeks. And this 6 weeks has been arbitrarily chosen so as to exclude viral arthritis, which are so very common in clinical practice. Small joints are affected, and as you can appreciate here, it is symmetry which is the hallmark, and involvement of the hand joints is the clinical phenotype of rheumatoid arthritis, and you have rheumatoid factor only in about 80% of the patients. So, in the remaining, you diagnose rheumatoid arthritis based upon the clinical phenotype that I have just described. The other way of looking at it is that should you encounter a positive rheumatoid factor, you need to be alive to the fact that there are several other conditions apart from rheumatoid arthritis. Other immunoinflammatory diseases like lupus, like Sjogren's, like scleroderma could be associated with a positive rheumatoid factor. 5% of healthy elderly individuals would be RF positive. So, do not jump to give a patient a diagnosis of rheumatoid arthritis based upon the mere presence of rheumatoid factor. Clinical correlation, like other branches of medicine, is mandatory. In our country, infections are so very common: infective endocarditis, tuberculosis, viral hepatitis, all of these could be associated with a positive rheumatoid factor, and I will show you a case vignette. Granulomatous diseases like idiopathic pulmonary fibrosis, sarcoidosis could be associated with a positive rheumatoid factor. So, all I am trying to emphasize is that you could have rheumatoid arthritis without rheumatoid factor, and the presence of rheumatoid factor does not mean rheumatoid arthritis always. Now, this is the story of a young plumber who presented with right wrist pain, and he had rheumatoid factor which was positive. The treating doctor gave him anti-inflammatory drugs and low dose steroids. Instead of improving, he continued to worsen, and this you can see is a suture mark. We did a biopsy. This is the X-ray. You see carpal crowding, and the biopsy showed necrotizing granulomas. So, this was tuberculosis of the wrist masquerading as rheumatoid arthritis, and the teaching learning point is that if you have a single joint involvement, be reluctant to make a diagnosis of rheumatoid arthritis. Rheumatoid arthritis is polyarticular, and in this situation, wrist involvement with a positive rheumatoid factor does not mean rheumatoid arthritis. So, rheumatoid factor does not total up to rheumatoid arthritis. Rheumatoid factor is an overrated investigation in rheumatology, and I think it's like the uric acid and the disc story. Every single person of the lay public, even if he has pain anywhere and everywhere, attributes it to uric acid. We as doctors sometimes perpetuate this myth, and every back pain in this country is a disc. So, I think we need to shift the spotlight away from uric acid and disc, and much in the same vein, rheumatoid factor, if you look at the performance characteristics of this test, diagnosis, it is not essential. Seronegative rheumatoid, you make a diagnosis on the bedside. Prognosis, it is one of the several factors. High titers may connote poor prognosis, but then you have other factors also which have an influence on prognosis, and importantly, it has no role in predicting response to treatment. So, one should refrain from ordering rheumatoid factor on every visit. Disappearance of rheumatoid factor is not the goal of treatment, and trying to tell the patient to get a rheumatoid factor on every visit is actually not born out of science, and it is a practice which should be actively discouraged. The autoantibody levels do not keep pace with clinical improvement or deterioration. This is the summary slide about rheumatoid factor. which mentions the fact that titers correlate poorly with response to treatment, and repeating rheumatoid factor is an exercise in futility. This led to this provocative editorial, that is it time to abandon the rheumatoid factor, and there is a lot of debate which goes on in rheumatology circles about this. Now, I come back to seronegative arthritis. We've talked about the limitations of rheumatoid factor. Now, rheumatoid arthritis is not the only entity. You have arthritides which are seronegative for rheumatoid factor. Do we have any other serologic investigations? And this is one which is now clinically available to our patients. Antibodies to citrullinated peptides. The point that I would like to make here is the sensitivity is no better than rheumatoid factor. It's not a more sensitive test, it is a more specific test. So, just don't be under the impression that if you order a CCP, you will pick up more patients. The advantage over rheumatoid factor is that the number of differential diagnoses with antibodies to CCP is the spectrum is much lower as compared to rheumatoid factor. So, in clinical practice, if you have a secure diagnosis of rheumatoid arthritis, you do not gain much by ordering an anti-CCP, and there is no point in ordering a CCP without first having ordered a rheumatoid factor. Anti-CCP antibodies predict erosive disease. So, one of the important things in rheumatoid arthritis is trying to prognosticate the disease outcome. Patients who are positive both for rheumatoid factor and anti-CCP would have higher erosion scores, signifying greater damage, in contrast to people who have only one antibody being present, and patients who are both seronegative for rheumatoid factor and CCP would by and large tend to do well. So, you could have all permutation combinations. Patient could be RF positive, CCP negative, CCP positive, RF negative, double negative and double positive, again underscoring the fact that it's your clinical recognition of rheumatoid which is far more important on the bedside than any serology. The advent of CCPs has meant that the universe of seronegative arthritis is shrinking. So, what we used to call as seronegative arthritis, some of them are seropositive by way of CCP, and as new markers get discovered, I think in 20-25 years there may be nothing like a seronegative arthritis. We now have antibodies to carbamylated P proteins which are being developed for rheumatoid arthritis, and with advancement of knowledge and refinement of technique, the serologies that are going to become available would perhaps mean that there is no patient who is truly seronegative. It is more a reflection of the inadequacy of science rather than true seronegativity. Let me now transition you from rheumatoid arthritis to the spectrum of seronegative spondyloarthritis. Now, rheumatoid phenotype is a women patient presenting with polyarthritis involving the small joints of the hands. In contradistinction, in the spondyloarthritis, you have a young male patient presenting with back pain which is inflammatory in character, and the joint involvement is mainly a large joint involvement of the knees, ankles, hips, asymmetrical. 2 ankles, 1 knee, 2 knees, 1 ankle, only 1 ankle. Lower limbs are preferentially affected. The small joints of the hands may be spared, and this is the spectrum of what we used to call as ankylosing spondylitis, and we now recognize that ankylosing spondylitis is but one entity in this broad group of spondyloarthritis. What about the seronegativity associated with spondyloarthritis? I think up until 1940, everything was rheumatoid. We now know that rheumatoid does not involve the spine except the cervical spine, and up until 1940 we used to call it rheumatoid spondylitis. Then was discovered the association of rheumatoid factor with rheumatoid arthritis, and it soon became apparent that young male patients with spinal involvement of an inflammatory character were a different group, and in 1963 the American College, then known as the American Rheumatism Association, adopted the term ankylosing spondylitis, and the terminology of rheumatoid spondylitis was relegated to the archives. So we move away from rheumatoid arthritis to the spondyloarthritis. In those days they were called seronegative spondyloarthropathies, and this is the image that at least I grew up with. When I was training at Patiala, this is the type of disease that we were taught to look out for: the bamboo spine, ankylosing spondylitis, and the time lag between symptom onset and diagnosis was on an average 7 years, because people take a lot of time to develop the bamboo spine, and by that time you have actually missed the bus, because it's too late to institute disease modifying drugs. Back in those days it didn't matter because the treatments were not available, and one of the major breakthroughs happened in 1973. Schloston and Brewerton discovered this HLA class 1 molecule, HLA-B27, and this facilitated or paved the way for early diagnosis of these conditions. And this is a father-son duo, and as you can appreciate, the father manifests the phenotype of ankylosing spondylitis, and this young boy with an inflammatory back pain has spondyloarthritis, but would not be called ankylosing spondylitis, and the emphasis is on early detection, and HLA-B27 was a major breakthrough. And lest we forget, women too get ankylosing spondylitis, and now the teaching learning point is that the male-female gender divide in spondyloarthritis is narrowed down, and it's no longer what we were taught 7 or 8 is to 1. Now people believe it's 2 to 3 is to 1. As we are able to pick up spondyloarthritis early using a combination of B27 by PCR and MR for picking up inflammatory sacroiliitis. And this is a trio of 3 young ladies, all with spondyloarthritis, and this is one message that I want to give across, that one has to think of spondyloarthritis in women also, particularly with inflammatory back pain. So there is more to back pain than disc, and we need to actively think beyond the problem of discogenic back pain. Now coming back to the spondyloarthritis, when we started we would call them seronegative spondyloarthropathies, and now the preferred nomenclature is spondyloarthritis. And if I have to put it in perspective, this is because we now believe that it is a totally different disease from rheumatoid arthritis, and it is like the population of US. You started by categorizing the population of US as whites and non-whites, and now you know that the non-whites have an independent entity. They could be Hispanics, Afro-Americans, could be Indo-Americans. So each of them is a distinct group, much in the same way. We now realize that the spondyloarthritis or the spondyloarthropathies do not owe their existence to the absence of rheumatoid factor. They have a distinct phenotype, so you no longer need a prefix. So this seronegative has been dropped, and the preferred nomenclature is SPA to define these patients with inflammatory back pain, enthesitis, which is pain along the tendon insertion sites, arthritis, which is asymmetrical, large joint, below waist involvement, and like many things in medicine, it is a misnomer. Rather than the involvement of the spine, It is the involvement of the sacroiliac joints which is the hallmark, and then you have the presence of HLA-B27. Let me welcome my distinguished predecessor, Dr. Muruganathan, the former Dean, the former President of the Indian College of Physicians and API. Welcome. The spectrum of spondyloarthritis is a big group. At one end we have ankylosing spondylitis, and I showed you the classical example of a stoop posture, but this is a big group which includes psoriasis, enteropathic arthritis related to ulcerative colitis and Crohn's, and all of us now know that Crohn's is not uncommon in our country, reactive arthritis which includes the Retter's syndrome, juvenile spondyloarthritis, and the entity of non-radiographic spondyloarthritis. The point that I would like to emphasize now is that you could have spondyloarthropathies without even back pain. This is like the story of heart failure with a normal ejection fraction, psoriatic arthritis without psoriasis, clinically amyopathic dermatomyositis. So much in the same way you can have spondyloarthritis without back pain, and it is this group of patients with peripheral joint involvement which are an important differential diagnosis when you talk of seronegative arthritis. Which are the entities which are predominantly peripheral? Reactive arthritis, psoriasis, enteropathic arthritis, and the undifferentiated or the non-radiographic spondyloarthritis can have a peripheral joint involvement which may superficially resemble rheumatoid arthritis. Now, having laid this background, let me spend the remaining 10 minutes of my talk focusing on a clinical approach to seronegative arthritis. Three things go into the making of a rheumatologic diagnosis, and this is a slide more by design than by accident. The font size is a reflector of the importance that you give to each of these three components, and the preeminent position belongs to history taking in rheumatic diseases, followed by examination, and investigations figure at the bottom of the list and are adjuncts but never substitutes for the reasoned judgment of a clinician. And we rely on pattern recognition. Now, you don't need to be a big wildlife expert to realize that this striped animal is a tiger and this is a zebra. So much in the same way you recognize the phenotype of rheumatic diseases. In rheumatoid arthritis, you have small joint involvement, hands are affected, bilaterally symmetrical. The spondyloarthritis affect the large joints, below waist involvement, asymmetrical. And enthesitis, rib pain, heel pain is the hallmark. Gender, much more in women rheumatoid, much more in men you have spondyloarthritis, and if you have inflammatory back pain with oligoarticular involvement of lower limbs, you are dealing with spondyloarthritis, and if you pay attention to this clinical detail, you can seldom if ever go wrong in your clinic on the bedside. So what is the algorithm? If you have an arthritis, it could be seropositive, positive for rheumatoid arthritis, and some of these may be seronegative. Those where rheumatoid factor is absent, you categorize them into two broad groups: those without inflammation, those with inflammation, and in non-inflammatory, the one which dominates the list is osteoarthritis. One of the big mimics is hypothyroidism, and there are two big mimics when you encounter musculoskeletal complaints. One is vitamin D deficiency, second is hypothyroidism, present all over the place. Let me confine myself to the seronegative inflammatory arthritis. Acute phase reactants are raised, ESR CRPs can be high, morning stiffness can be there, patients improve with activity, typically worsen after rest. That is the profile of inflammatory arthritis. and you don't need very high-tech medicine, just count the number of joints that are affected. Single joint is monoarthritis, 2, 3 or 4 joints are oligoarthritis, and when you have 5 or more joints you call it polyarthritis. And this counting is not because rheumatologists like arithmetic, but because it helps you to narrow down your list of differential diagnoses. Single joint involvement, always remember 2 entities, crystals and infection. It could be gout, it could be other crystals. Infection, if it is acute onset septic arthritis, indolent onset tuberculosis, and I am not talking of, I see my senior Dr. Bakshi sitting here. From an orthopedic perspective, trauma can be important, but from a medical perspective, physician's perspective, these are the only 2 important things, crystals and infections. Single joint involvement, be alive to this. Then it could be the beginning of a polyarticular disease, and in such people, if you observe the patient over a period of time, other joint involvement will become apparent, and these are examples. Typical podagra. If you get a tophus here, you don't need any other investigation. Only one thing gives rise to a tophus at the ear. This is gout. Upper limbs can be affected, midfoot can be affected, and this is tophaceous gout. You don't need any investigations. Oligoarthritis, involvement of 2, 3 or 4 joints. Gout could be monoarticular or oligoarticular, rarely even polyarticular. But the biggest group here are the spondarthritis, and I have already described that. Again, to reiterate, don't go with a mental image of angst-spond. This is a big group. Angst-spond is one polar end of the spectrum. You have several other conditions in this, and this is one example. Single joint involvement, young male patient. Please do not rush to label it tuberculosis based upon some dubious PCR report that you get. Many of them are having peripheral spondarthritis, and they will not volunteer history of back pain, and this is the reason for delayed diagnosis. Again an example, young male patient with a knee involvement. Please be diligent in ruling in or ruling out spondarthritis. And if you look at this sausage digit, if you see it once, you will never forget it again. In rheumatoid arthritis, you have plump in the middle, slender at the edges. This is the fusiform swelling, and if it is a cylindrical swelling like a sausage, there is no differential diagnosis. You are dealing with either psoriasis or a reactive arthritis, and if you carefully examine the patient, you actually need a modicum of investigations. This is again another example of dactylitis. Enthesitis is involvement of the heel. Plantar fasciitis, costochondritis, young male patient, you are very likely dealing with spondarthritis. These are examples of dactylitis. Finally, the last group in seronegative arthritis, the biggest group is when you have multiple joints being affected. It could be seronegative rheumatoid, it could be psoriasis, it could be lupus, or it could be systemic sclerosis and a few other conditions. Hand examination holds the clue. In rheumatoid, it's symmetrical involvement. In psoriasis, DIP joints are affected, and unless you are in the habit of looking at nails, the nail paint in women can mask the nail changes of psoriasis, and in osteoarthritis, you get a bony swelling. So this is the bony swelling of osteoarthritis, the Heberden's nodes, whereas the rheumatoid swelling is boggy, psoriasis a florid case, in some more subtle swelling, but psoriasis is asymmetrical, nail changes, and you could have psoriasis in hidden areas. So make it a point to look below the turban, behind the ear, or look at the nails, and this could be this is the natal cleft, what is the gluteal cleft, and psoriasis in hidden areas. This is around the umbilicus. So this gives you the clue to the etiology of the seronegative arthritis, which otherwise would remain an enigma. Lupus. Now this is serologically very prolific, but rheumatoid factor may be absent. more in women. The arthritis is indistinguishable from rheumatoid, but is correctable, by definition non-erosive. This is the Jacob's arthropathy. So, ladies and gentlemen, I would like to summarize my talk by mentioning that seronegative rheumatoid arthritis is an important condition. Other things also come in the differential diagnosis. By definition, this is one where rheumatoid factor is absent. The attention to number of joints affected can help you to narrow the list of differential diagnoses. Single joint involvement, crystals and infection. Oligoarticular involvement, the biggest chunk is the spondyloarthritis group. Polyarticular involvement, rheumatoid or lupus or psoriasis. I would also like to mention here that pattern recognition is far more important than labels. The treatment of most of the inflammatory arthritis remains similar. Leave aside crystals, but whether it is seronegative rheumatoid, enteropathic, you use the same group of drugs like sulfasalazine, methotrexate, and seronegative inflammatory arthritis is a concept which is evolving. It allows you to institute treatment with the liberty to revise and refine your diagnosis as the clinical picture evolves, and this has some limitations, but it helps you to institute treatment after narrowing down the differential diagnoses. Thank you very much for your kind attention.
Hello.